I welcome everybody to this KeraKonnect E CME series, and today's topic is going to be cataract and coexisting corneal pathologies. And I have with me eminent panelists on this, chairpersons, Dr. Quresh Maskati, Professor J.S. Titial, Dr. Srinivas Rao, Dr. Nikhil Gokhale, Dr. Vikas Mittal, Dr. Geeta Iyer, Dr. Janankar Mehndi, Dr. Himanshu Matalia, and all the speakers. And we will now begin with the program. So I would be talking to you about an overview and introduction of Facoemulsification in the presence of corneal haze. Dr. Praveen Krishna from L.V. Prasad Eye Institute will be talking to you about anterior lamellar keratoplasty and Facoemulsification. Dr. Samar Basak would be talking to you about DSEC triple, and Dr. Rajesh Vogla would be talking to you about DMEK triple, and Dr. Paras Mehta will be talking about PKP triple. So we will be talking about corneal transplantation procedures, and the irony of the whole thing is that we don't have enough corneas and we don't have enough patients as of now for these procedures. We have after this three video challenges, slit beam retroillumination assisted phacoemulsification, which will be presented by Dr. Rakhi Kusmesh. Then Dr. Shahnawaz would be presenting his video on phaco with corneal opacity, and Dr. Kavita Rao will be taking us through the video on phacoemulsification in the presence of Salzmann nodular degeneration. So starting with the first talk, I'll just be giving you an overview of phacoemulsification in the presence of corneal haze, and there are no financial or proprietary interests, and I would be discussing the off-label use of trypan blue dye and air. And I think the bigger question in all these cases is whether we would do cataract surgery alone. It could be SICS or it could be phacoemulsification, or it could be a combined procedure which could be cataract surgery with corneal transplantation. And I think there are various factors which determine whether you would do a single stage or a combined procedure. It depends on the type of the corneal opacity or haze, the location of the haze, the expertise of the surgeon, the availability of the donor corneas, and the visual requirement in terms of risk-benefit analysis. And this is essentially what we published, and this gives the algorithm of the management of a case with cataract surgery with corneal opacity. So if it's a small central corneal opacity which is partially covering the visual axis, you can do phaco alone, and if it covers a little more, then you may have to do optical iridectomy. And if the superficial part of the cornea is only involved, you can get away by doing a PTK with phacoemulsification. However, if the greater depth of cornea is involved, for instance, up to 1/3 of the cornea is involved, then you may have to do superficial anterior lamellar keratoplasty or SALK triple. And then if it involves more, then you may have to do ALTK triple. Or if it involves still further, then you may have to do DALK triple. If the corneal opacity which involves endothelium only, one can do DSEC or DMEK triple. And when all the layers of the cornea are involved, then one has to do a PKP triple. So this is a review article that we published regarding the same. And I think this is itself is a whole talk on how would you select intraocular lens power in these cases. And suffice it to say that we generally like to use a monofocal intraocular lens, and often keratometry is not possible. We have to depend on peripheral video keratography. IOL master again is often not possible, and biometry has to be done using ultrasonic B scan. Now there are several requirements, and as I show you the movies, I would be talking about these tips and these tricks. The first part is the planning of the incision. So the planning of the incision has to be in such a manner that at least one half of the cornea is there, which remains clear, so that at least one half is the area from where you can do the various phaco maneuvers. So this is just to show a case of chemical injury with a paracentral corneal opacity going right up to the periphery. Trypan blue staining has been done. And again, just as you go underneath that haze, you have to go in one go so that you don't lose the edge of the rexus there. And because if you lose the edge of the rexus underneath the opacity, it is difficult to obtain, especially if it is more centrally located. Then of course you have to do nuclear emulsification followed by irrigation and aspiration, and then a foldable intraocular lens implantation is done. It is important in all these cases also to always see that your retroillumination is on. because if there is a opacity which is present in these cases, then this orange reflex always helps you in tackling these cases with phacoemulsification. Uh, this is a case of fixed dystrophy with cataract, and I think again this itself is a whole talk on how to deal with fixed dystrophy and cataract. This was a case who didn't want a corneal transplantation, so you can see on the IOCT that there's bedewing of the corneal layers, and phacoemulsification is then done just as one would do routinely, taking into consideration that one has to use OVD, which is dispersive, such as a viscoat, so that it coats the corneal endothelium, and then intraocular lens implantation is done. And this is not going to last for too long. So because there is a lot of corneal edema here, and then in the second stage or in the same stage, one can even do an endothelial keratoplasty. This was a case again of healed keratitis with a paracentral corneal opacity, and optical rhyndectomy has been done. Hard cataract, trypan blue staining of the dye is being done. And again, when you go underneath that opacity, you have to go in one go, and sometimes you have to even uh, do a little bit of globe maneuvering, pull it to the other side to see where your area of the rexis is, and sometimes the rexis has to be done in such a manner so that it becomes eccentric, because this is the area where you will be seeing and also the area where the patient would be seeing. This is the eccentric crater which is being done for this case, and again the retro illumination has to be on. You have to do phaco in situ. So just as you chop, you eat, you chop, you eat, so that the orange glow gets better and better, and then the contrast gets better and better, so as to allow you to see these grayish fragments against the orange glow. And the second instrument is very handy. Sometimes these fragments are camouflaged underneath the opacity, so it helps to get it into the area of the visualization, and then foldable intraocular lens can be put in. And this was a case which had a phthisis bulba in the other eye because of corneal transplantation infection, and so didn't want a corneal transplantation in this eye. Now, again, here, in fact, this was the case which was for optical iodectomy. And just as optical iodectomy has been done, it was realized with the help of the vitrector, it was realized that there is a cataract which is present. And such cases become very tricky, because then how do you plan the IOL power in these cases? So, zonular cataract was present, so capsulorhexis was then done, followed by irrigation and aspiration, because this was a relatively younger patient, and so we could get away with this. And then followed by bimanual irrigation aspiration, because it is difficult to obtain the lens matter from within the capsular fornices. And then a lens is being put in the bag, and then again one can do what is called as the pilocarpine test in the end. That is, you just put air bubble and then put pilocarpine, see how small the pupil is, and then accordingly one can do the pupilloplasty can be done with the help of the vitrector itself, so that you enlarge the area from where the patient is going to see. Again, this is a case of dry eye with very hard cataract. So you have to again expand your area of visualization by doing, essentially following the same principles. The incision has to be here, because this part of the cornea is clear. And again, it's a very hard cataract, but still eccentric crater has been done, and then one can again put nylon hooks to expand the area of visualization. This is a case which already somebody had done a corneal transplantation procedure, full thickness PK. The patient had a white cataract, and then a pannus which is there. In all such cases, if you remove the pannus, you can see actually underneath it is quite clear. So one should always take that chance of removing the pannus and seeing the underneath part of the cornea. If you do anterior segment OCT, then also you can decipher this. And whenever it gets blurry, just put that blob of viscoelastic, so that for a split of a second, this becomes clearer, and it can be then visualized properly, and then at least allow you to initiate the maneuver and then complete the maneuver. This is a case which was then completed in a normal fashion after doing the rexis. Now, this is a black and a white cornea, so somebody in a corneal opacity has tattooed it also, and there's adherence which can be seen on the intraop OCT microscope. So this adherence is released first. Again, the pupil is small, so nylon hooks have been put there. From the area which is relatively clear, the capsulorhexis is initiated, and with the help of the capsulorhexis forceps, you move into the clearer area. Even this IOCT helps you to visualize the area of the part of the rhexis which is camouflaged underneath that opacity, and helps you to complete it. And again, hydro procedures are done, followed by Facoemulsification. The retroillumination again has to be on, so that you can see the area of, you can see the grayish or the whitish fragments underneath that orange glow. Bimanual irrigation aspiration also helps in this case, although it is being done by coaxial here. And subsequently the lens is put, and once you put the lens, it gets very clear. This trick can also be done in those cases where corneas are hazy and you can't even make out the cortical matter. If you put the lens, you can see it better because the optics get better. And even by pulling the nylon hooks, the pupil, which is so seemingly small, is actually become bigger, and then you can even do, with the help of the cutter, the pupil can be fashioned. And like I said, the pilocarpine test can be done in the end to see actually which is the area where your pupil is impinging and which is the area which is clear of it. So this is the air which is being put, and then you know that little bit of this part of it is clear and the patient can see from here. So we did a lot, many cases in cases of ocular Steven-Johnson syndrome, and again these cases are very tricky. In these cases, you can't do a corneal transplantation, for instance, in this case, because they're high risk for grafts. So you have to again put nylon hooks. The incision is as shown. The endoilluminator is put inside to see where you have to do the chops, and then now the endoilluminator is pushed is outside to see where the margin of the capsulorhexis is, so that the intraocular lens can be placed inside the bag. So these are some of the cases which were dealt with like this, and they do get very good visual acuity, considering that prior to the surgery they are hardly ambulatory. And this is yet another case with good visual acuity. And this is a case of of perforated PUK, for which patch graft was done, and then there's a cataract here. The cataract was addressed, and the post-op visual acuity was again good in this case. So this is yet another case. Of course, there remains corneal irregularities and ectasia part, and SJS is known to have ectasias. There is thinning in these cases, and again, this case is hazy, but then it allows the patient to move, and you have to counsel the patients in such a manner. So then you can combine these procedures also, and I think this would be dealt by different speakers, but this is just to show that you can have phaco with DALC, and then DSEC triple can be done in these cases, and then DMEK triple also can be done in these cases. So to summarize, for high risk cases, one can do phacoemulsification first, and then see how it goes, and then probably do a corneal transplantation procedure if it is required. But for those cases which do have good prognosis for grafts, then combined procedures can be done. Thank you very much for your kind attention. And if there are any questions, we would be happy to take them. Uh, Are there any questions in the chat box, Shabina?
No, Dr. Namrata, as of now, there are no questions in the chat box.
Okay.
We'll keep taking as and when they
come. So I think we will move on to the next talk.
Ma'am, may I ask a question?
Yeah.
Ma'am, is there any significant role of pre-operative ASOCT in prognosticating the visual outcome in these cases? Is there any role of doing ASOCT in these cases?
The ASOCT would always be useful, because you would know by looking at the anterior segment OCT also, it will corroborate basically where the level of the opacity is. So it can help you in that. It can help you in planning, which layer is diseased, and it can help you in planning your surgery, especially if you've thought of combining it with the if you're planning to do a combined procedure. So it can help you in those things. it does have an important role, and if you have it, it's a good tool to have.
Namrata, there was a question from the audience about what happens in these cases if you get a PCR.
It's a disaster, a complete disaster if you get a PCR. And I always say, and I'm sure even it will be emphasized, that if you are doing an endothelial keratoplasty for them, it is better to do a phaco and you're not able to see anything. It is better to do a phaco more in the anterior part of the anterior chamber rather than, getting a PCR there and then messing it all up. And sometimes it does get so hazy that you can't see and there is a PCR. Then in those cases, it is best not to implant an intraocular lens, because then you don't know what you are doing actually. And when you do EK or endothelial keratoplasty, in those cases, if you do remain more towards the anterior part, it's okay, because you are anyway going to replace the endothelium, but you shouldn't have a PCR.
Okay.
So I think we can take the next talk. And the next talk is by Dr. Praveen Krishna, and he is going to talk about anterior lamellar keratoplasty and Facoemulsification.
Thanks, Namrata, for starting with that amazing bouquet of challenging cases for cataract surgery with corneal pathology. So what I'm going to focus on in the next 8 to 10 minutes or so is to basically speak about anterior lamellar keratoplasty and cataract. This talk, I'm going to focus both on just lamellar keratoplasty that's done by manual dissection and deep anterior lamellar keratoplasty. So what I'm going to show you, or at least what I'm going to try and share, is a case of ALK followed by cataract surgery, along with some of the things that are important to note during the surgery, as well as the planning for such a patient. Very briefly about DLK followed by cataract surgery, because the parameters as well as the investigations are just about the same between ALK and DLK, not too different. And then finally, we'll finish off with doing DLK along with the cataract surgery at the same sitting. So amongst all of these, the determinants of what we should start planning is the timing between the two surgeries, between the initial surgery and the second surgery. I won't go into the details of the choice of surgery between ALK or DLK. That depends on the surgeon's choice and the kind of pathology that is in the cornea. What is important from the point of view of IOL power calculations for a case such as this? The variations in the surgical procedure that you need to be cognizant of when we're planning DLK or post-LK cataract surgery, and what is the effect of cataract surgery on the graft itself. So I'm going to start with a young male that we saw in December 2015. So he had a blunt trauma to his cornea during Diwali because of a firecracker. And when we saw him in December, about a month and a half after he had this injury, this was a picture. He had a corneal scar that was right in the visual axis. He also had a cataract at this point of time. What we could see off in the retina seemed to be quite okay. He did not have any significant angle recession. Vision was not great. His vision with plus 1.5 in the right eye was about 20/80, so not too bad as well. We did an OCT. We found that the opacity that he had was limited mainly to the anterior stroma. The thickness of the opacity in the thickest area was about 180 microns. And you'll see that the epithelium already started to cover the irregularities in the surface of the cornea to sort of regularize the surface. The entire corneal thickness was about 500 microns. And so for this patient, we waited for a significant amount of time, and then we planned to do an LK instead of a DLK because the opacity was mainly in the anterior stroma. So very briefly about what we did during the LK, he had a semi-dilated pupil, and so I used a 8 millimeter vacuum prefine to make the initial trephination to a depth of 300 microns on the cornea. Then I used the dot Melis dissectors that you use for manual dissection in DSEK to dissect out a lenticule of tissue that was about 300 microns deep. And you'll see here that the cornea is relatively clear at this time, and we did not need to dissect any deeper. We did the same dissection using the same trephine, no change in the diameter of the tissue from a donor cornea, and then we sutured the lamella or the anterior cap onto the donor cornea using 12 sutures. So that's about the end of surgery for this patient, just to give you an idea of what we did during surgery. So this is the same patient about a week after the initial surgery. You'll remember that he had a vision of 20 by 80 initially. That diminished to about 20 by 200 after surgery, probably because of the astigmatism that he had. And you can see from the slit picture that the opacity is gone, and he has a very clear anterior stroma. That's the OCT at 1 week, and you'll see again that the thickness of the corneal lenticule is about 300 to 350 microns, but the epithelium, about 150 microns of stroma that is left behind in the posterior lamella. So this is about 1 month later. He was 21, 25. The cornea looked relatively clear. What you see is an opacity in the visual axis is his cataract. And so at this point of time, which is an important determinant, is you need to speak to your patient to tell them that visual acuity is not going to recover completely immediately, and you will require a second surgery after a significant period of time. And this is what we told this young gentleman. This is, again, the OCT showing you the same measurements that I spoke about a little earlier. So about 9 months later, he had uncorrected visual acuity in the right eye because we couldn't get a good glow on retinoscopy of 21-25. All sutures were removed at this time, and this was, then we started to plan that we should start to do cataract surgery for this patient. But obviously, we waited to ensure that the topography was stable. This is his topography in July of 2017, about 9 months after, 8 months after the initial surgery. You'll see that the average K is about 40 diopters at this point of time. This is after all sutures are removed. About 7 months later, after follow-up, the average K was about 41, almost the same, not much change except for a diopter. Astigmatism was about minus 4.6. Vision was still 21-25. So we waited for another 3 months, and in April 2018 is when we took him up for cataract surgery after we ensured that the topography was stable and was also predictable on the topography. The A scan showed the astigmatism about the same, about 4 diopters of astigmatism, and we chose IOL of plus 17.5. We chose a toric IOL with a potential residual spherical error of 0.52. So this is the surgery, again, not very different from a routine cataract surgery. The only thing that you probably should be aware of is when you make your incisions, you should stay short of the graft-host junction. In this case, it's not that important because it's an anterior lamella. And so we chose to do a clear corneal incision. And after the regular cataract surgery, we realized that he had a PC plaque. So I tried to peel the PC plaque during surgery, but it was fibrous, and so I was not able to peel it. So I implanted my lens, and then I did posterior capsulotomy using a retractor to ensure that the PC plaque was removed. So this was a toric IOL, and after the PC plaque was removed using the retractor, did a limited anterior vitrectomy, and then we positioned the IOL. And after you position the IOL, also made sure that we put some air in the anterior chamber so that the IOL doesn't vault anteriorly out of the bag, which again will lead to positioning issues. And this is the end of surgery, all wounds sutured, and the surgery went off pretty well. So on post-op day 1, this is a post-op day 1 picture. He was 20 by 60 already, and he seemed to be healing quite well. Pupil was still dilated, and his pupil remained dilated, mid-dilated, even after surgery because of a few sphincter tears that he had because of the trauma. About 1 month after surgery, the patient was doing really well, and he was best corrected visual acuity of 20 by 20 parts, and he was extremely happy. And you'll see that the LK is almost blended into the cornea, and we've got a really good outcome for somebody who had quite poor vision and a corneal scar earlier. So just to emphasize the staged manner in which we should do these surgeries. This is about 3 years follow-up after we saw the patient, and this is his refractive error right now. So what is interesting to see is on the eye trace, the IOL is about 16 degrees off target. and his refractive error is plus 1.75 with -2 at 180, and he's 20/20 parts. And his astigmatism on the cornea actually had come down to about 2.5 diopters, and so the IOL that we'd use inside the eye was actually overcorrecting him slightly, and that's the residual power that he had. But he was still very happy with his glasses, and I think this is a fantastic outcome from what he had. Now, what is important not to do in a case like this, where you have a corneal opacity and you have a cataract as well, is in this case that we actually saw in the clinic today. So this is a patient of granular dystrophy, and because most of the opacities were in the anterior stoma, the surgeon elected to do an LK. So this is the picture of the LK at 1 month post-op. Patient was 21/25. And I'm not sure about the reason why the cataract surgery was done early, but then the cataract surgery was done without the sutures being taken off at about 6 months post-op LK. And the patient is 20/100 at this point of time. And if you look at his topography, he still has a significant amount of astigmatism with about 8 sutures in the eye. Vision is 20/100, which now limits the ability to improve his vision by either reducing the astigmatism, which you can correct to a certain extent by removing sutures, but not completely. So this is probably not what you should do. You should wait for most of the sutures to be out, or all the sutures to be out, wait for the topography to be stable, and only then do cataract surgery for a good outcome. In DALK, the other option is using a custom toric IOL. I'll not go into the details, but just to tell you about the option that is available. This is a patient post-DALK with a very high residual astigmatism, almost 11 diopters. And then this patient, we used a smart toric lens with this notation. And then this patient did really well. And this patient was 20/30 unaided after the customized toric lenses. Now, this is not usually required post-ALK because the astigmatism is usually a little lower, but might be required after PK or DALK, just to show you that this is an option as well. Now, the other option is doing cataract surgery combined with the lamellar keratoplasty. And this is a lady who came in from Oman, whom we saw in July of last year, with a post-trachoma scar, vision of 20/320. She was a 65-year-old lady, and she had a significant cataract in the eye as well. Now, the issue was this patient was going to be with us for only about 10 days or so. So we had to plan a combined surgery for the cataract as well as a corneal opacity. That's the depth of the corneal opacity, and you'll see that it is pretty much the entire thickness of the cornea. So we thought that we'll try and do a combined surgery with a standby tissue available as well. So this is where I started, an 8mm partial trephination, and this is typically what I do for DALK surgery. I took off the cap and then tried to see if visualization was good enough for me to do cataract surgery. I figured that it was okay, but I thought I'll go a little deeper. So at this point of time, I tried to inject an air bubble. I did get some air diffusing into the stroma, and then a partial bubble, which I expanded by injecting HPMC inside the bubble, which actually increased the size of the bubble quite significantly. Then I took off the additional stroma, made the slash into the incision, and then dissected the part of the potential space between the predesmase layer and the posterior stroma to ensure that I have a complete dissection. And then use a typical divide and conquer method to remove all the excessive stroma from the Duas layer. And this is how the patient looked, very nicely dilated pupil, and only the Duas layer and the desmase membrane is intact right now. So I elected to do cataract surgery using this. So put viscoelastic inside the eye. The capsulorhexis was pretty straightforward. No real challenges with the capsulorhexis. Just injecting viscoelastic to keep the AC formed. I used a sterile incision because I didn't want to incise the desmase, and then a temporal sterile incision, and then a hydro. And then I started to do a phaco. The only thing that I tried to do in this case is I tried not to remove the air bubbles that are present inside the anterior chamber. So I have a sense of the depth at which I'm operating. So I did divide and conquer, relatively hard cataract, and you'll see that my parameters were relatively low. I reduced the bottle height, and I was doing a phaco very slowly. I kept putting viscoelastic on the surface of the eye to get better visualization. And after the nucleus was out, then the cortex aspiration was pretty good. I was operating on a Infinity Phaco machine, and the fluidics are fantastic, no financial interest. But then again, I didn't have any shallowing of the anterior chamber, and that I was very careful about. Then the lens inside the eye, I used a single piece hydrophilic acrylic lens. And then I thought my capsulorhexis was a little small, so I went in and enlarged my capsulorhexis on both sides to prevent fibrosis of the anterior capsule. And then with my right hand, I kept putting viscoelastic, removed all the visco inside the eye, ensured that I washed out all the visco from the surface of the eye, sutured the incision, and this is the donor graft for the patient, peeling off the Descemet's membrane. Once I did that, it is like a straightforward DAL. So the only difference in this case was the fact that we did a phaco with the Duas layer and the Descemet's membrane intact. I was not sure I'll be able to be successful, but I had a PK tissue standby. And if I had to convert, I thought I would. And that's the end of surgery for this patient. Patient did relatively well. We only have post-op 1-day pictures. And this is her on the post-op 1 day, 21-25, post-op 1 day. And this is the OCT about 10 days post-op. She was 20/80, and because of the removal of the cataract, her vision was pretty good, and she was quite happy as well. So to summarize what we just went through, if you have a combined cataract as well as an anterior corneal pathology, I would always do the ALK or the DLK first if you're planning to do this surgery. And once you finish this, then you make sure that you plan to have your sutures out in between 12 to 15 months for ALK. For DLK, I would prefer to wait a little longer. This also is tempered by the fact that you should look at your graft-nose junction. If it's well healed, you can take off your sutures earlier. If it's not, then you probably would like to wait a little longer. After you take off your sutures, 3 months of stable topography to ensure you don't have any IOL surprises. And then you can plan either a toric or a custom toric or a regular IOL. And in case you have to operate a case of a combined DAL kind of phaco and IOL, it is possible. It's a rare indication, but only if the cataract cannot wait or if your patient wants only a single surgery. Otherwise, you always would like to do the corneal procedure first, followed by a cataract surgery. Thank you very much.
I think that was a great message. Do your corneal surgery first and then cataract. And I think, Praveen, you are very brave to be doing a phaco procedure, overlying your Descemet's and your Duas layer. But what if Duas layer was not there? You think you would have been able to get away even then with the phaco procedure?
No, I think if it is only Descemet's, I wouldn't even have tried. I would have just gone ahead and converted to a PK and removed the cataract anteriorly. Because of the fact that there was pre-Descemet's Duas layer, I figured that I thought I'll take a chance to see if I'll be able to complete the surgery, and it seemed to be okay. I was not very sure, and I wouldn't recommend that everybody try this at home. But then it seems that it is a possible procedure.
No, it seemed very nice. It seemed it is possible.
The only point I would like to make in that is that when you are doing a phaco with the pre-Descemet's layer intact, you can connect a separate AC maintainer and keep the fluid running so that whenever you're removing your probe from the eye or you're doing any maneuver exchanging, the chamber doesn't collapse and it remains formed throughout. So thereby, you don't have the problem of even if you had a surge or something like that, which is very unlikely, but it kind of adds another safety margin to keep the chamber formed whenever you are going in or coming out of the eye. So this is something that can be done. The other thing that I've done is I punch out a soft contact lens, which is 0.25 millimeters smaller than the size of the trephination that I've done. So what I do is I put some viscoelastic, dispersive viscoelastic like methyl cellulose, and then I put the contact lens over that within the area of trephination. So the contact lens basically, because it's 0.25 millimeters smaller, it sits there. And then you don't need to, the surface remains quite clear. So you don't have to, so the convexity of the surface is maintained. Unlike when you put in a layer of viscoelastic, initially you see very well, but as the viscoelastic goes away, you feel that the visibility may be affected. So that kind of makes it easier to do, especially if the visibility is not too great.
I think that's also a very useful tip for cases when you're doing, in very steep corneas, you're doing in cases of keratoconus, you're doing a cataract surgery. Again, they have recommended, Dr. Christopher Roquano has recommended that you put a RGP contact lens or a hard contact lens over it so that you don't get distortions and you can still carry on with your phaco surgery. But I think that was a great tip about the ultra smart toric IOL. And the only thing is, there is a question there that if you have a PCR like that and you have a DALC over there and you still put toric intraocular lens, do you think there is going to be, change in the rotation of the toric intraocular lens in such cases? How are you going to address it if it occurs?
I think the rotation of the intraocular lens is determined by the adherence of the lens to the majority of the capsule that you left behind and the fibrosis around the haptics. So I don't think making a posterior capsule opening that is about 3 or 4 millimeters wide is going to determine the instability of the lens from the point of view of rotation. What can happen is when you leave your anterior chamber shallow, and if your lens moves anteriorly and if it comes out of the bag, then you'll have a tough time putting the lens back into the bag. So in such a situation, it's very important to ensure that the AC is completely formed at all times when you take out your probe. So that's the reason why at the end of surgery, you saw me put an air bubble. So the IOL doesn't move anteriorly, and then complete my suturing and then remove the air bubble at the end.
Praveen, another option can be the second step of YAG caps, and if at all YAG caps is not possible, we surely can do a small vitrectomy. I mean, surely that can be another way to handle it.
Okay, there are a lot of questions on IOL power calculation, and we had planned, like Nikhil has also written another webinar on IOL power calculation in cases of when you have to do cataract surgery in cases of corneal pathology. So, Professor Titrial sir, would you like to comment on?
It was a wonderful video demonstration, Praveen, really such a beautiful steps one shown in such a difficult situation. But as far as I am concerned, we do have access to automated systems. If it depends on the level of opacities in these stroma. If it is superficial, less than 250 microns, we do a SALC procedure there, which is sutural surgery. And subsequently, you can plan cataract surgery, which is easier in these cases. If it is a mixed stroma, then ALK can be done. Deeper, he showed that deep anterior keratoplasty can be done. One thing he nicely highlighted is the host graft junction has to be perfectly opposed in all lamellar keratoplasties, so that you don't induce too much astigmatism, and subsequent management can be easier. And the first case he showed, after waiting for such a long time also, that keratometry keeps changing in these cases. So you are not sure what is the exact time for an intervening, you can say, elective cataract surgery for these patients. But I think after suture removal, waiting for 2 to 3 months is a good time for any keratoplasty, and more so for a lamellar keratoplasty also. I always prefer a sequential surgery for these cases. One thing to be highlighted, all these patients who have anterior stromal problems or a scar, these patients do have significant ocular surface problems also. The post-op management has to be very carefully done for these patients. They are not like a routine cataract patients. So you have to look for evidence of surface problems, epithelial defect coming up sometimes these patients. So you have to be careful giving too much of steroids or anti-inflammatory non-steroidal drops, because they can cause damage to the ocular surface. So that point has to be really assessed for these patients.
Dr. Srinivas Rao is there. Dr. Srinivas Rao, your comments on the, yes, you have to unmute yourself. You have to unmute.
I'm sorry. Nothing really more to add. Maybe Praveen can just add a quick comment on the IOL power calculation that he did for this particular patient.
For the one in which the LK was done before and then the cataract, it was pretty straightforward because we had the K readings. Yes. But for the other patient, what I do is I use a standard K of 45, which is the average K that I've noticed that I have after doing a keratoplasty with my sutures in. And that's the K that I use to calculate IOL power.
Okay. So thank you, Praveen, for that excellent talk. And now we move to the next talk. which will be given by Dr. Samar Basak, and it is going to be on DSEC triple. We are going to have in part 2 of this webinar a very detailed discussion on IOL power calculation, as was planned by Dr. Nikhil. So we will do that in more details there. Dr. Basak sir, please, on DSEC triple.
Yeah. So thank you, Namrata, for this webinar. Very great talk by Praveen. And can you see my slide?
So you have to, it's not sharing the share screen.
I've shared screen.
So you opened your presentation.
Open my presentation. It is open already. No.
The presentation is open, sir. Then share screen. In that share screen, the window will come where your presentation can be seen. When you, that window is coming in that share screen.
That is not coming.
So you want your PowerPoint or your video? Yes, now it is. Yes, now you can just.
Yeah, now it is fine now. Yep. Can you see this?
Yes.
Yeah, we can see.
Yeah. So I'll be talking on DSEC triple. So I'm sharing the old videos actually. I think the today's era, I mean not today's era, 3 months back era, the DMEK triple is the main choice, but still DSEC triple, there are certain roles. And you know that now in a COVID era, we do not have surplus tissue and we do not have, in fact, standby tissue. So most of the difficult cases, in fact, today I have done one DSEC triple rather than DMEK triple. It was a difficult one. So I'll share some of the cases. So this is a typical one. So this is very old patient presented with advanced Fuchs dystrophy with vascularization in the lower part. You could see AC you cannot make out, cataract probably NS3, and other eye you see that, and he is referred for PK IOL. And other eye, if you see that, there is already the problem with PK triple. So this patient, I did actually manual SICS with manual DSEC, and you see that the most of the time you cannot see, but if you do a lot of manual SICS, you could do the surgery, and this is typical Vectis delivery, and cortical cleaning one done, and epinucleus was removed and cortical cleaning was done. Then a PMMA lens was given. So this is unlike your sophisticated phaco surgery. This then we did, it is a very old video. You see that I was using that reverse 26 gauge needle for desmetectomy, then the desmetodexis stripping. So then the usual procedure of DSEC, and though it was difficult, now the visibility was a little better. And then it is like you throw air and then you do the DSEC procedure. So this patient actually did well. And you see that in 3rd month post-week, the patient regained that 6/12 part vision, and later the patient was doing fantastic. And the same eye, we did again the PK procedure in this case in the left eye, and that also failed after some time. So this is the scenario where the advanced Fuchs and the patient, you cannot visualize. Still, if you had a chance, if you do a good cataract surgery, whether by Facoemulsification or by manual SICS, then your job is done. You can always try a DSEK surgery. The similar kind of case, but probably these are the case where I should try DMEK triple in this case, but that time DMEK was not known to me, but I did manual. This patient was extremely doing fine and she's following up regularly. Even in the last year photograph, you see that the patient was doing very fine. This was 3-month picture and you see the corneal thickness was 739. Later it was reduced to 658 and CD was 2000 and later it was reduced after 12 years, 1528. So this is one of the indication of doing DSEK triple in the current scenario. Second scenario we do always, probably this is one of the indication we do more nowadays. So corneal ulcer, therapeutic PK, failed graft with complicated cataract, then DSEK triple most of the time and sometimes DMEK triple. So, and you need to have certain consideration like minimum interval and what is the status of the other eye. So you could wait for few months to still after suture removal, but sometimes the cataract gets very faster and basically white cataract, then you have to, even before cutting your suture, so you have to do the surgery. Then again, the Faco or manual SICS and DM stripping is usually required in these cases after therapeutic PK because of inflammatory debris lies on the endothelium. And a lot of RCM is very common, then optical PK, release of pus, then posterior synechia may require 50-60% of the cases. Donor size is usually larger because the graft is larger. And again, I prefer to go with scleral tunnel, or I could open the same graft host junction in some of the eyes. So this is, you see, this is one patient and she is one-eyed, and within no time, within maybe within 3 to 4 months, the cataract was white. And you see there is a lot of bleeding while doing the anterior synecdoche. There is a lot of bleeding happen, and you remove the desmet, and at the same time you will see that lot of retrocorneal membrane attached at the periphery, it started growing, and you see there is a bleeding point here, and in spite of, you cannot stop this oozing after trying with air, and you carry on your, these are softer cataract, so the typical stop and chop. And you see that even after removal of this thing, the bleeding is still going on. And you need to put again air to see that before stopping the blood, in this particular case, I had to put the graft and then put air, and you centered the graft. This is a typical 8 millimeter because the previous graft was larger, and secured the sutures. Now there is blood in the interface, so you have to drain the blood by giving venting incision. So you see that whenever you give venting incision, there is the blood is coming. So that is the end of you keep the air for a longer period of the time, because in these cases, the donor detachment is higher in some of the eyes. And this patient, you see that post of 3 months, she was only one-eyed and 6/18 vision, and this patient is still doing very good. So RCM is actually a problem for after therapeutic pre-K, and you need to, sometime the RCM are thinner, and it comes easily with your reverse Sinskey hook. But sometimes RCM is very thick, like in right-hand side picture, and you need to take the help of some tooth forceps to take out that thick RCM. Unless you remove that, your visibility will be poor. Then only you can do your cataract surgery. And venting incision is also required in some of the eyes because the interface may not match in many of the cases because of the graft, sometimes eccentric. And you see the lot of viscous material trapped in the interface. So you could drain those viscous material. So this is another typical that kind of patient. You see that these patients do well with dissect triple rather than picket triple. And this is another lady is going good for last 6 years, and she is doing extremely well and with a good cell density of 1100 plus. So, but complication does happen, especially the graft rejection is higher. And usually 70% of the graft in this category, like dissect triple in therapeutic PK, they survive with 20/60 or better vision after 3 to 5 years. But you have to consider the other, there may be some limiting factor like RCM, scarring, secondary glaucoma, higher astigmatism, all these things you have to consider. So this is another patient. This is another situation. I get here more often that this patient is also referred from Tripura for PK IOL. He is one-eyed actually, teacher. And you see that he had an history of recurrent attacks of herpes simplex virus keratitis. I see a lot of this, and I have a series of like 25, 30 cases of dissect, then later on DMEK about more than 25 eyes. And see that left eye was thicical. And if you see this patient, cornea is pretty thick, but only the supratemporal area is visible. There is no active inflammation, so to say. And typically this patient, I starts with prednisolone and oral acyclovir 7 days prior to surgery. But again, what Namrata pointed out, that retroillumination is one of the important, that is the part of the microscope. That microscope actually gives you the best view, and you can use light pipe also, that also helps. But retroillumination, coaxial retroillumination, especially with Lumera microscope, that usually gives the best view. And from one side, you can still do little stop and chop, and you remove this cataract. Then cortical cleaning with, I always use bimanual cortical cleaning. And you see that one side your visibility is almost nil. So this Acrisop single piece IOL was given in this particular eye. And because it is a dissect triple, I entered through the scleral tunnel. I don't prefer to put any corneal suture. So the desmetrexis is difficult, and I have found that there is a adhesion always with where the inflammation is of endotheliitis is more. Then this is just like typical. I always use the Stacco technique and then unfold it, and then air. So this part is not difficult, but initial phaco part was difficult. And so you center it and you close the incision. So this patient from Tripura then put on all oral prednisolone and oral acyclovir and topical prednisolone. This is after 3 months picture, and he improved to 6/18 part. Oral acyclovir continued for 1.5 years, in fact, in this photo. There are some layers of lipid keratopathy. Eventually, those are also cleared, and this is After 6 months, patient very happy with a good specular microscopy. But all these are and those era when I didn't do DMEK surgery, but now this is in the DMEK era. Still, we need dissect triple in some of the eyes. But as I said earlier, that COVID era, you have limited tissue. So like this is the case, same case. Again, from Tripura, I have a good referral from Tripura because there is no corneal surgeon there. So they all referred, they used to come to Bengal and I do many of their cases. And again, this case, PK, IOL, recurrent HSV keratitis in all kind of keratitis. So I thought if I could do Faco in this case or any kind of combination, SICS Faco combination like halfway Faco, then you crack the nucleus and then your incision will be smaller, then I could do DMEK. And I did DMEK in this DMEK IOL, and this patient was doing absolutely fine. This was day 15, and after 9 months, the patient was 6/12 part, very happy patient. But again, in this, if today I am getting this case, I will not try DMEK triple because the probability of tissue loss and also complication is, you have to keep in mind. So now the situation is different, but Rajesh will tell about the DMEK triple more deep details. Thank you very much for your kind hearing.
Thank you, sir. I think those were really complex cases for which you did DSEK, especially the one where there was so much of bleed, and despite that, the DSEK graft could go in and did well in the post-operative period. When you are doing in case of therapeutic PK, the DSEK graft, sometimes the sutures are there. So do you think they would be, not allowing the graft to attach in the post-op period? Or do you size it like this so that the graft edges don't impinge on the sutures?
Yes, that point is rightly said. But if I get a chance to remove those suture, I will try those DSEK procedure later, DSEK triple. But sometimes the cataract progresses so fast. You see that young patient, then you see suddenly white cataract, 30, 35 years, because of trauma, toxic material during the surgery and previous trauma during previous therapeutic PK, all leads to white soft cataract. And this thing you cannot wait for suture removal. PK, the graft is usually larger, say 9.5, 10 or 10.5 millimeter. So you have enough graft size, so you could sizing the graft very well. Usually 8 is good enough in this, and still you have a lot of space. If you have smaller, you can give 7.5 or even 7 millimeter graft that way.
Any other question anybody would want to ask? Nikhil, would you want to ask anything from Dr. Basak?
I think there is one question for Dr. Basak. Dr. Debapriya Chatterjee wants to know can you explain a little more about the venting incision and need for that?
Venting incision, it is a preference, surgeon's preference, but normally in a normal DSEK, people used to do venting incision, many surgeons, but I typically use in post PK, any kind of post PK, because of posterior edge of the host graft junction, sometimes if you do anterior segment OCT, there may be little ledge, and if you put your graft, right sizing of the graft within that graft host junction, sometimes it's difficult. Then you may have a potential space between the interface. So there are, because we keep a little bit Hilon while inserting the graft, there is visco mixed fluid may trapped into the interface, and venting incision that way helps to drain those. Venting incision also required to centering the graft. Sometimes the previous graft may be little bit eccentric, then your graft usually doesn't want to come to that well centered. Then from the top, you can use like 30 gauge needle or a 15 blade to center the graft. It serves two purposes, the centering as well as venting.
Yeah, under the air, once we put the air inside and then we...
yeah, of course.
Yeah.
Of course, after putting air. Right.
And it also opens up one more thing which we would prefer to do would be in ASOCT preoperatively, to know the graft host junction, especially the posterior graft host junction. So, which allows us whether there is a good opposition there or there is a ledge there, and which can be a very good tool there.
Actually, 4-quadrant ASOCT is better unless you have a huge limbus to limbus AOCT. Most of the ASOCTs are 8 millimeter. So if you use 4 cuts in 4-quadrant, that gives fairly well idea which part there is overhanging edge. And also ASOCT helps in recognize RCM. So you have distinct 2 layers like RCM, and also you can see the endothelium DM complex.
Another one for you, Dr. Praveen has posted. Somebody asked, what is the time between your, what is the earliest you would do a DSEK in a failed graft? I think we are discussing more about grafts and less about cataract, but the question is, what is the earliest that you would do a DSEK in a failed graft?
No, not earliest, minimum 3 months time, but you wait. But especially if you have suture and cataract is not there, so you wait. And the condition of the other eye, if the patient is one-eyed, and you have to intervene early. So there are a lot of factors when you intervene, but typically you should not touch those cornea before 3 months.
Dr. Janankar Mehdi wants to ask a question. Dr. Janankar?
Yeah, it's regarding the bleeding. Would you like to stop for the bleeding?
I tried in these cases. I waited for 15 minutes. It stopped momentarily because it was I think it was dialysis happened while doing anterior synecholysis actually. So little bit iododialysis, and this happens in post-therapeutic PK, a lot of bleeding. Sometimes you put air, wait for 10-15 minutes, bleed stops. But in this particular case, it didn't stop.
So there, everybody is asking this question, why didn't you wait for bleeding to stop? So I think that's it.
No, this is the truth. No, you have to wait. But again, that sometimes it happens that bleeding again, it happens because you have done phaco. Again, the rebleed happens from that. The clot dislodge and bleeding happen. One
tip which I can give is that when you are doing this peripheral synecholysis with the blunt cyclodialysis spatula, if you encounter too much of resistance, then instead of using that pressure to separate the synechia, I would prefer to go with the micro scissors, and I would cut the adhesions rather than trying to use blunt force to separate. Thereby, you can prevent the iridodialysis. So most of the time nowadays, I like using the MST micro scissors, and I go and I cut out the peripheral synechia. Whatever you cannot release by gentle pressure using a cyclodialysis spatula.
Also, Rajesh, we'd like to cut out more towards the cornea side so that it's less of a bleeding and iris tissue cutting there. Yeah.
There's one more question. Dr. Sonia Kothari wants to know that should we strip the Descemet's membrane to improve the visibility before doing the cataract surgery in patients with endothelial case?
I think this question for me, Rajesh, everybody. But we have seen that if you are very quick enough to do the cataract, it's fine. But if you remove the endothelium, Descemet stripping, then if you go and if your cataract is difficult, then you will lose the clarity. Sometimes we try both the ways, epithelial removal, sometimes halfway you do the cataract, then your visibility is poor, then you remove it. Again, as soon as you enter the globe, the cornea will be edematous. That is my concern. Rajesh can also answer. So I don't like to strip the Descemet before doing cataracts in majority of the cases.
I think for the similar reason that we all don't want cornea to become edematous and then become hazy, because it will imbibe in the fluid that will be going through our phaco probes. So we all like to save the desmids for as long as it is possible, despite the fact that it is diseased, and then take it out only later. So I think with this, we will move on to the next talk, and the next talk is by Dr. Rajesh Fogla. He would be talking about DMEK triple. Thank you for those very challenging examples, sir. Each one of them was difficult.
Thank you, Namrata, for making me part of this KeraKonnect series. The DMEK triple, basically DMEK and cataract, what are the various options? So what has changed in cataract surgery? In modern times, there is a significant shift in patients' expectations for post-operative visual outcomes. And most patients are not satisfied just with 20/20 or 6/6 alone. And they want good vision both for distance, intermediate, and near as well. And they also want a very rapid visual recovery. And especially with the newer technology in cataract surgery, with the advent of femtosecond laser-assisted cataract surgery, the Varion system for IOL positioning and newer IOL designs, especially toric IOLs or the trifocals or the enhanced depth of focus lenses, patients' expectations have definitely increased from what they want from cataract surgery. And similarly, in corneal transplant, compared to the routine penetrating keratoplasty, with the advent of DMEK, we are doing a very selective replacement of the dysfunctional endothelium. The visual recovery is fast. We are able to provide predictable refractive outcome compared to penetrating keratoplasty. The risk of rejection is minimal, so the fellow eye can be operated relatively early, just like doing a sequential cataract surgery one after the other over a very short duration of time. And this report from the American Academy published in 2017 shows that the results of DMEK are definitely better than DSEK in terms of visual outcome, the rejection rate, and the induced refractive error. And the cell loss is comparable between the two techniques. And that's why DMEK is now becoming the most preferred technique of endothelial keratoplasty. The clinical scenarios in which a patient may present to us with coexisting endothelial dysfunction and cataract is either that the patient, what we see most frequently in our practices, the patient has already undergone the cataract surgery, the cornea has decompensated. So he presents to you with a pseudophakic bullous keratopathy. At times, you will see patients with lenticular changes and advanced endothelial dystrophy. Sometimes you see patients with ICE syndrome also presenting with cataract or early cataract and shallow anterior chamber, or patients who have suffered viral endotheliitis and they have corneal edema and they have lenticular changes. So this may be a scenario where both may present together. And the third scenario is acute dystrophy in younger patients where you get central corneal edematous changes, but the lens is still not significantly involved with the changes. So when you have a coexisting cataract and advanced endothelial dysfunction, the options that you have are basically either you can do a staged procedure where you do the cataract surgery first, followed by a DMEK at a later stage. You can offer a combined cataract surgery and DMEK, or you do the DMEK first and then follow it up by cataract surgery. So let's look at all these three options. When you do a cataract surgery followed by DMEK, the advantage is that you just do the cataract surgery alone, and all the other complications that may be associated with DMEK in terms of detachment of the donor, any rejection or primary graft failure or interface problems like infection, these can be eliminated. The medications post-operative usage will be for a shorter duration, and patient may require less follow-up visits to the clinic. And if you do the cataract surgery, you increase the AC depth and you increase the working space for a subsequent corneal surgery. And also, you minimize the risk of endothelial cell loss if you do the DMEK first and followed by a cataract surgery. And if you do the cataract surgery first, the IOL capsular bag, because the capsule fibroses, the lens IOL capsular bag becomes more rigid and they become much more stable. So it becomes much more easier when you're doing the DMEK surgery at a later date. The difficulty arises is what is the ideal power calculation. We know that when you do an endothelial keratoplasty, there can be a slight hyperopic shift. So that has to be taken into consideration when you choose the IOL. And the second is, if there is some amount of epithelial edema, sometimes the keratometry readings may not be accurate. And doing stage surgery, basically two surgeries, so it's increased cost for the patient as well. So when you are doing a stage surgery, decision making for Fuchs dystrophy, basically this study from Seedsman, which was published in 2005, they found that if the pachymetry is more than 640 microns, the rate of keratoplasty required is in the range of about 22.2%. And for patients with less than 640 microns, only 2.4% required a subsequent corneal transplantation. So basically, if you have corneal thickness less than 650, cell counts more than 1000, maybe you can definitely do a cataract surgery alone. If it is pachymetry is slightly more than 650 and your cell counts are still between 800 to 1000, you can do a cataract surgery, but explaining the risk that the chances of requiring an endothelial keratoplasty may be greater. So if the cell counts are lower than 800, it's better to combine the two surgeries. And especially the risk of increased endothelial failure would be if there is already an existing epithelial edema, there is presence of deep folds in the posterior cornea, you have some amount of subepithelial fibrosis as you see on the anterior segment OCT. If the guttae are not restricted to the central 5 millimeter zone, if they extend to the periphery, or if you're not able to get any endothelial cell measurement on speculum microscopy, and especially older age group with shallower anterior chamber and more lenticular changes, it's better. The chances of endothelial failure are much higher. If you're doing surgery, the Facoemulsification is the preferred technique, although in some cases you may do a manual small incision cataract surgery or extracapsular, especially if the cataract is very hard. IOL power calculation, you aim for a postoperative myopic refractive error of about -1, -1.5. Choose a hydrophobic IOL, monofocal aspheric design. It's important that you use really sharp knives because the descemet's membrane is attachment is not very tight, and at times you can get local DM detachment if you use blunt knives. Use a soft cell technique to protect the endothelium, or combination of dispersive and cohesive viscoelastic, and try to avoid intracameral medications which can be detrimental to the endothelial cells which are not functioning optimally. Secure the wounds with suture and avoid stromal hydration, because the stromal hydration itself can sometimes predispose to detachment of the descemet's membrane. And it's advisable to leave a mid-size air bubble at the end of surgery. So this air bubble would tamponade any minor DM detachment adjacent to the incisions and prevent them from progressing further. Post-operative, you may have to use steroids for a longer duration of time and maybe greater frequency. I usually also like to add topical sodium chloride 5% for 2 to 4 weeks. Monitor the IOP, watch out for DM detachment. So anterior segment OCT is quite useful to monitor. And if there is corneal edema, it takes about 8 to 12 weeks before deciding whether this is going to resolve or it may finally require a corneal surgery. And if the cornea does fail, you can always go back and do a DMEK, and it gives you good visual outcome, as in this case that you can see. A combined cataract surgery with DMEK eliminates the need for multiple surgeries. The outcomes are comparable to stage surgery, and the refractive outcomes of DMEK are definitely better than other endothelial keratoplasty procedures. The only problem is if there is severe corneal edema, it may affect the visibility for cataract surgery, for which you have to debride the epithelium, maybe remove the descemet's membrane, use dyes to stain the anterior capsule, and sometimes use light pipe as well for improving the visualization. In this situation, when there is severe corneal edema, the K readings are often affected by the increased corneal edema. You may have to sometimes take the K readings from the fellow eye because of the enantiomorphism. The average K readings are usually symmetrical between the two eyes. And in a younger patient, if you do a combined surgery, there can be a loss of accommodation when you implant a monofocal lens. This is a paper of Lasser and Frederick Cruz, and they looked at the outcomes of DMEK triple, and they found that the addition of cataract surgery to DMEK did not affect either the endothelial function or the graft addition, and did not increase the likelihood of postoperative complications, and they have fairly good visual outcome. And this paper from the Price group, Sunita had worked on it. 2014 it was published, and they compared pseudophakic eyes which underwent DMEK compared to eyes which underwent combined cataract and DMEK. And they found that at 6 months, the corrected distance visual acuity was better in the group that had the combined surgery. And in terms of graft failure or air re-injection rate or endothelial cell loss, between the two groups, it did not show any difference. They had an increased rebubbling rate of almost about 30%, and this was attributed to the use of viscoelastic during the surgery. So they modified their technique later on by washing out all the viscoelastic, and they dropped down the rate to about 16%. So this is a patient who had undergone a combined procedure, and you can see a 3 years follow-up, looking good, unaided vision of 20/30, and just has a minimal cylindrical error of about 1.25 and a good endothelial cell count. And the rapidity with which the visual recovery occurs allows you to do sequential surgery. So for this patient, in 1 week, we operated the fellow eye also. We did a combined cataract and DMEK. And this is a paper, again, published by the Price Group, where they showed that you can safely perform within 1 to 2 weeks sequential surgery in the fellow eye when both eyes are affected with Fuchs dystrophy and cataract. The surgical tips when you're doing combined surgery is that you have to ensure accuracy of keratometry reading. Often in patients with central corneal edema with localized Fuchs, there can be microcystic edema which can affect measurement of the K reading. You can apply hyperosmotics like sodium chloride or even topical glycerin to clear that and then take your keratometry reading, or you can take the reading from the fellow eye. In terms of choosing the IOL, when I'm doing the combined surgery, I like a hydrophobic acrylic, but instead of a single piece design, I like a 3-piece design because I find that that kind of holds the IOL much better within the bag as compared to a single piece. You should make your capsular axis slightly smaller in size so that the IOL does not pop out every time the chamber shallows. And you wash out the viscoelastic material completely prior to inserting the donor. So when your pupil is dilated and you're putting your IOL into the bag, you don't immediately put in a myotic to constrict the pupil. You first go in, remove all the viscoelastic from the anterior chamber and also from within the bag. And after that, you put in a myotic to constrict the pupil and then proceed further with the DMEK surgery. And you have to minimize iris trauma during the surgery. And if you use myotics and postoperatively try to dilate the pupil intermittently because you want to avoid any formation of posterior signage. And postoperatively, you have a slightly higher incidence of cystoid macular edema in these triple procedures. And there was no difference in the visual outcome between the eyes that developed CME and the eyes that did not develop CME. And they usually respond quite well to medical therapy. But this is something that has to be taken into consideration. And this paper from the Japanese group published last year, they looked at several factors which could be responsible for development of CME. So the only factor that they found which was statistically significant was the iris damage during DMEK, and they concluded that surgeons should attempt to minimize any trauma to the iris. What about DMEK followed by cataract surgery? Advantages: it preserves accommodation, especially in patients who are less than 50 years of age. You get better K readings for the cataract surgery post-resolution of the corneal edema. You get better refractive outcomes. And in this paper, again by Frank Price group, they compared between the eyes that had combined surgery, whereas the eyes which had stage surgery. The uncorrected visual acuity of 20/25 or better was 65% in the stage surgery as opposed to 39% in the combined, 20/40 or better in 97% versus 80%. And if you do a DMEK surgery alone, there is an increased risk of cataract development, especially in patients above the age of 50 years. Almost 76% have progressive lenticular changes, out of which 33% require cataract surgery. And also, there can be an increased risk of endothelial cell loss during the subsequent cataract surgery, especially if there is shallow anterior chamber, hard cataract, or a non-dilating pupil. So this is a patient, 42-year-old with Fuchs, central corneal edema. So here we performed a DMEK surgery alone, and you can see by day 5, the cornea is already looking clear. And by day 30, the cornea was clear. Patient returned back to 20/20 and was very happy with the vision. That's the anterior segment OCT, pre and post, showing the change. So what happens in terms of the hyperopic shift? This paper from Melis shows that in DMEK, you actually don't get a hyperopic shift as you see with DSEK because you don't make the posterior curvature more myopic by addition of the lenticule. What happens in Fuchs dystrophy is that when you get corneal edema, the edema pushes the posterior layer, the posterior cornea towards the anterior chamber, thereby reducing the curvature. So the power of the posterior corneal curvature reduces, and that basically increases the overall power of the cornea, making the eye a little myopic. So there is a little myopic shift as the cornea, as the edema progresses. When a DMEK is performed, it's the central corneal edema that resolves much faster. So the posterior curvature, it becomes much more steeper in the center, making it, increasing the power of the posterior cornea in terms of the minus power. So that gives a relative hyperopic shift. And when the peripheral corneal edema subsides, this hyperopic shift goes away over a period of 3 months. And also they looked at a paper looking at the cataract surgery following DMEK. and they found that this can be successfully performed without any risk to the DMEK graft, and the cell loss is usually in the range of about 5 to 10%. And if you take good adequate precautions, you can minimize that and it has no impact on the visual outcome. So currently for Fuchs dystrophy, we looked at the corneal thickness as an indicator of endothelial function, and we also look at the slit lamp examination of how the cornea, overall appearance of the cornea is, and we ask for early morning blurring of vision. But it fails to detect subclinical corneal edema. So are there any new modalities? So this is a nice paper by Sanjay Patel published in Ophthalmology 2018. So what they found that if you look at the tomography images, you don't see changes in the anterior curvature, both the height map or the placido disc. But if you look at the elevation map of the posterior curvature, you will find that there is a focal area of posterior surface depression. So as the corneal edema happens, the posterior surface is pushed towards the anterior chamber. So you see the red patch that is indicating that that layer is pushed posteriorly to the reference plane. So that is a sign of subclinical edema. And also, if you look at the pachymetry map, you find that the central cornea becomes thicker and the paracentral cornea remains thinner. So this again gives you a clue as to that there is some amount of subclinical edema. And also, if you compare the ratio between the central and the peripheral corneal thickness, in a normal eye, the central cornea is thinner than the peripheral corneal thickness. So the ratio is always below 1. Whereas in Fuchs dystrophy, as the central cornea thickens, the ratio between the central and the periphery comes closer to 1. So this also, if you follow it up, using this ratio also, you can look at progression of the Fuchs dystrophy. And with the advent of high resolution anterior segment OCT, you can reconstruct the posterior, the appearance of the posterior curvature, the posterior surface on a 3D map. And that can actually show you the guttae, where are they located, how dense they are in the center, or whether they are extending to the periphery as well, especially when you cannot obtain very good specular image map. So in conclusion, for a flow chart of managing, I just try to put everything together. If you have a Fuchs dystrophy patient who's asymptomatic, you don't need to do anything, you observe. If you have a patient who's visually symptomatic, you examine the eye. If there is a clear lens, and if you find that the guttae are located only to the central 4 to 5 millimeter area and there are adequate peripheral cent count, you can consider doing a decimet stripping only or a decimet stripping without endothelial keratoplasty, which takes about 3-4 months for the edema to clear, especially with the use of rho kinase inhibitor. This may be successful. If it fails, then you have the option of going back to DMEK. If there is a clear lens, you have the corneal guttae which are beyond the 5 millimeter, you have inadequate peripheral cell counts, but your anterior chamber depth is more than 3 millimeter and the pachymetry is more than 650, you consider doing just a DMEK alone. But if there is a symptomatic patient where you have corneal changes and you have a cataract as well, there you have to take the indication that if the package is less than 650, cell counts are more than 1000. But again, take into consideration what is the anterior chamber depth, because the anterior chamber depth is shallow, you can successfully do a DMEK, but the subsequent cataract surgery is more likely to damage more endothelial cells. Also, you need to have a well-dilating pupil and the cataract should not be very hard. So then you can just do a cataract surgery alone, use a hydrophobic IOL, because the hydrophilic IOL may have more chance of opacification with the gas tamponade, and DMEK can be performed whenever the need arises. If you have endothelial cell count less than 1000 and the pachymetry is more than 650, and anterior chamber depth is more than 3 millimeter, well-dilating pupil, you can do a stage surgery where you do a DMEK alone, especially if the patient wants to have a toric IOL or a multifocal IOL later on. So you do a DMEK alone, get the resolution of the corneal edema, which allows you better planning for cataract surgery, come back and do a cataract surgery using a premium lens. But if the anterior chamber depth is shallow, non-dilating pupil coexisting problem, then do a combined surgery, use a hydrophobic 3-piece lens. And later on, whatever refractive error is there, you can further refine by doing a laser surface ablation. So this is in short about combined DMEK and cataract. How do you manage? I've not shown any videos in my presentation because it's just an 8-minute presentation. So if you go onto YouTube and follow my channel, you will find a lot of videos on triple procedure showing a combined cataract surgery and a DMEK procedure. Thank you. Thank you for the question.
Thank you, Rajesh, for those wonderful insights into how to manage cataract with the Fuchs dystrophy and when to do DMEK triple and what are the problems thereof. If there are any questions from the panelists?
Just one comment, like as students, we were always taught that whenever we keep seeing patients who have bad endothelium, so when their corneas are not decompensated, just take a note of the keratometry reading, because that might help you in future when the patient really comes to you with corneal edema or decompensation. So that record may be useful. So that was one
Absolutely.
thing for all
Yes.
of us. That I think is quite useful, because sometimes patients disappear, come after a year, and then you can probably use your old readings, or your old A scan can really be useful when things were better.
Even readings from your autokeratometer, because every time your patients come, a refraction is done, you have the strip of autokeratometer reading which is there. Most of them are on a thermal paper printout. So if it is there, make sure that you write down the findings. Otherwise, later on, when you want to go back to them, these findings have the paper, the ink has faded off and you can hardly make out what is there. But as the point that you made out is very valid, that you can keep record of the keratometry reading and then that can be used later for a corneal.
Yeah, the thing, of course, is very difficult to get specular counts with our routine specular microscopes. So sometimes, it's quite tricky with the thick Descemet's and Fuchs especially. Like post PK cataracts, with the graft is clear, you can get good cell counts. Even with low counts, you can get away with cataract surgery. But in Fuchs, sometimes it's very difficult to figure out what you are seeing, and sometimes they may be very erroneous, because sometimes you have these general ophthalmologists sending patients for evaluation whether I should do triple or I should do a stage procedures, and the cell count images can be very misleading at times. So there's just a general comment.
So I think that early morning blurring of vision, typically if the patient says that when they get up in the morning, the vision is a bit fuzzy and they say colored halos and it takes about 2-3 hours for the vision to clear. That again is a very useful sign that tells you that this cornea is more likely to decompensate. And also anterior segment OCT, if you look at the cornea, if you see the Descemet's to be quite thickened, then sometimes these patients are more likely to develop a post-operative DM detachment as well. I have had patients with cell count of 1,000 or more, and I've gone ahead and done a cataract surgery very atraumatically. But even then, post-operatively, sometimes they spontaneously have a detachment of the DM, and that even after several attempts at rebubbling, refuses to stick together.
So such patient, Dr. Nikhil, I would rather prefer Pentachem and see, as Dr. Rajesh was talking about central to peripheral ratio, and see the progression of the pachymetry, which can give us a better idea about if the cornea is decompensating.
Yeah, so that's what. In fact, you have some patients where the corneas may be very thin to begin with, and there are some patients where we know there is a lot of variation in the corneal values. So don't take an absolute cutoff. We need to look at all the things, not only just the absolute value. And as Himanshu said,
If you look at the normal distribution of corneal pachymetry, it can vary anywhere between 450 to 650 even in a normal population. Yes. Although a majority of them will be between 500 to 600, but you have outliers on both sides. So even on the higher side, between 600 650, you can have patients with normal endothelial function and just have thick corneas.
In fact, progression for Fuchs, I rather prefer doing a Pentachem as judging the progression than only the specular, because specular is going to come as a big black color blob, whereas your Pentachem progression or pachymetry map would tell you a lot of story that it's still holding on or it's going back.
Maybe Dr. Basak can tell something about DSO, because he has been doing. Have you been doing them for Fuchs dystrophy cases? So these are early Fuchs that you have done. You have to unmute yourself.
I don't know. I let Sir say, and then.
No, his microphone is muted. You have to unmute himself.
Yes, so I don't know. It doesn't.
So I did only 5. Then I showed the result in the KeraKonnect last year. Yes. So I was not happy. So I stopped doing it. Typically, I tried to find out the cases who had only central edema. So I used to take specular from 5 places, like 4 quadrants and central. And if the peripheral cornea, there is little gatteta or no gatteta, I used to pick up those patients. But you know that 3 of my patients, I did one DMEK in one of the cases, and 2 patients ran away. And 2 patients are surviving with a matter of follow-up, maybe now 2 years. So, and vis-a-vis in other, and I selected the cases where other eye I have done DMEK because the patient could not blame me. So I said that I will give a try. If it is good, then fine. So, but if you do in the first eye, then you will be in trouble. So 3-4 months waiting for cornea clarity and then patient able to see. And otherwise this patient was like 612, 618 vision initially. And suddenly their vision dropped to 660 or less than 660. They are angry now. So
What is your choice? What is your choice of IOL when you do a DMEK triple? Praveen and,
normally I give a single piece, and as you said, in some of the eyes I use multi-piece, especially in myope, where the back I presume that back size will be larger, then I give a multi-piece. But
what about
otherwise,
toric
toric I have done if the toricity is more than 3 diopter, then only I considered, and multifocal I did one only. Because other I had multifocal, that is the only option. But otherwise, routinely, I don't prescribe multifocal.
Dr. Chetyal sir, what is your take on type of intraocular lens in DMEK triple? Would you do these multifocals or EDOF lenses, or?
Both of them were rightly, explained the choice of lenses. I think all of us are going to use a monofocal lenses, hydrophobic lenses for these cases. Multifocal, I have not done in any of DSEC or DMEK patient till date. And I think even I had 1 or 2 patients who had a multifocal in other eye, but they are not doing well. So I decided to do a monofocal lens in this eye so that they can see better. In fact, that's a better choice for these patients because they already have cornea which is compromised. Their contrast, everything is poor. And such cases, multifocal may not do well. I'm not sure the future lenses which are now coming with a better contrast may be better, but considering the fact monofocal, which gives a best contrast, will be the best choice for these lenses. As far as asphericity concerned, I have not thought about that, looking for negative or positive or zero asphericity, but routine lenses which we are putting, which are a negative asphericity, it does well in these patients also.
One other point when you speak about the progression of corneal thickness, like Himanshu mentioned on the pentacam, it also is important to note the time of the day that the scan is done and the time from the patient that has been awake that he's come to your clinic. Because sometimes you'll get very variable readings if you see the patient in the morning
early
versus
morning
evening.
versus evening.
Yeah. So just make a note in the file how many hours the patient has been awake when you do the scan. That'll help.
Okay, I think
the problem is more there in institutes because you see patients throughout the day. For those of us in private practice to see patients only for 2.5 to 3 hours a day, it's always within half an hour gap this way or that way that we've done a pachymetry. So that doesn't apply to private practitioners. Yeah.
I think, rightly said by Dr. Rajesh, not only the parametric which are going to test, it has to be correlated with the symptoms of a patient. I think we have been talking on patient symptoms as one of the major criteria for deciding the type of surgery which you're going to do. I think that's one of the most important things. On that, then you take pentacam or ASOCT or other things that will make things better for judging patient for a suitability.
In fact, last when I spoke to Frank Price, his view had completely changed. Now he is a big proponent of doing the DMEK first and then come back and do a cataract surgery at a later date because he feels that you're able to give a much better refractive outcome to the patient because once the corneal edema has settled over a period of 3 months, you're able to get much better measurements and give much better, outcomes post-cataract surgery.
What is the chance of detachment of a DMEK graft?
It doesn't happen. Even I've done in a lot of my cases, that chances of detachment are less. The only worry I would have is increased endothelial cell loss. That again, if you're doing a grade 2, grade 3 cataract is fine, but if you have a shallow chamber or a dense cataract, you might be damaging your DMEK graft. So I think that is where you may have to. So if you, the younger patient phakic eyes where I've done DMEK, I found that over a period of 3 to 5 years, they have come back requiring cataract surgery. So it's not like in these patients who are in their early 40s, if you do a DMEK alone, they can pull on till 60s, 70s. No, because they use steroids, and over a period of 3 to 5 years, they all come back and they require a cataract surgery.
So it is a second insult to the endothelium.
Correct.
First insult you are doing during DMEK and second insult during. So the rate of cell loss, I have done few, the rate of cell loss is more compared to regular cataract surgery.
Yes.
So that is the question. So I prefer anybody is above 40, is a patient, because 2 eye surgery people do not like, cost, everything what you have pointed out.
Okay, so I think every time we try to discuss cataract and IOL, we drift to cornea more, and then every time somebody has to pull you to discuss cataract. Anyway, so now we come to the next talk, and when everything fails and all else fails and there's no other option, it is PKP triple. So that will be given by Dr. Paras Mehta. Paras, are you there?
Yeah, thank you, Dr. Namrata, for giving this opportunity to be part of this KeraKonnect CSI initiative. I will just share my screen. Are you able to see my screen now?
Yeah.
Yeah. So the topic which I would be covering would be a PKP triple procedure. I think it is not moving.
You have to go to slide.
I'll just, yeah. So we all know that many times patients do present with combined like corneal disease and coexistent advanced cataract, and one needs to address both these challenges to achieve better visual rehabilitation. Then the question would arise whether it should be one step or a sequential. It's always better if you can do a sequential, but again it would be at the cost of compromising the donor endothelium. Sometimes the cataract is so advanced that there is no chance of doing it sequential. So we'll limit this talk to a combined PKP with PKP triple, like with cataract surgery. In the era of lamellar surgeries, still PKP is a rescue procedure in many situations, like where the endothelial cell layer is non-functional and associated with a dense scar. And in addition to it, the patient has a very advanced cataract. For example, you see it here. This patient has a very advanced, like almost, totally opaque cornea except the peripheral part, very dense scar with spheroidal changes on the top, and you can hardly, after dilating the pupil also, you can hardly see the details inside. So when do we consider PK with cataract surgery? When there is a dense full thickness corneal scar, or there could be adherent vascularized corneal scars, sometimes very advanced macular dystrophy with involvement of the endothelial layer with advanced cataract. Then maybe probably the DALK and a cataract surgery may not work in those cases. Penetrating corneal injuries with substantial tissue loss and traumatic cataracts are the ones. The commonest indications would be for PKP triple would be again, HSV corneal scar with advanced cataract, acanthamoeba keratitis, corneal scar with advanced cataract, sometimes thermal or chemical injury with a scarring and central scarring and advanced cataract, severe corneal trauma, hydrops, dense corneal with a dense corneal scarring, where you cannot do a DAL in any case, like the posterior layer is also involved into that, and vascularized corneal scars with dense lipid deposition. Sometimes post-traumatic blood-stained cornea also would require a penetrating keratoplasty when there is, it would be a triple procedure when there is an association of a cataract in these cases. While doing a PKP triple, the many challenges which we face, number one is IOL power calculations. Corneal topography will change post-PKP. Intraoperative challenges as it is an open sky procedure. Sometimes the vitreous upthrust may make the procedure nearly impossible to complete. or sometimes you may have to suture the donor cornea before even inserting the intraocular lens inside. Intraoperative complications can make the situation more challenging. There could be positive pressure if the eye is small. One needs to tackle synechia posterior to the corneal scar in case of adherent glaucoma. The anterior capsulorhexis or a capsulotomy can be tricky. Cortical removal is all the more difficult due to lack of benefits of the closed chamber, which we, now we are very so much accustomed with Facoemulsification in routine use. If the eye is soft, then also there are more issues of nucleus delivery and cortical cleanup. So let's look at each of them individually. The IOL power calculation. This was briefly touched upon by Dr. Praveen and in our discussion. One can consider taking K readings of the fellow eye if the fellow eye is normal, or if the patient is one-eyed, maybe probably or single-eyed, you may not have that option available. If that is not available, then can consider an average post-PK K readings. Like usually 44 or 45 diopter of K readings would work well. Usually 44, 45 works in my hands. You can calculate the average K readings looking at your, 15 to 50 graphs, and then probably you can decide what would be your average K readings in those cases. Still, there could be surprises if both the eyes are extremely asymmetric. So one needs to consider and explain it to the patient beforehand also, so that they don't, later on complain about some refractive surprises. The preoperative considerations would be one can use preoperative IV mannitol to make sure that the IOP is low and the eye is soft. A good massage and pressure after a perivulvar block. If you have a competent anesthesiologist, maybe you can even plan the surgery under general anesthesia. If it is possible, you have a good setup for GA. Use an ideal wire speculum to avoid any pressure on an open globe, because that can also lead to a lot of intra-op problems. Take 2 bridal sutures for assistance for globe rotation during suturing the graft. Use of Fleringa's scleral expansion ring can be a very good option if you are accustomed to use that. Mark the cornea with trephine for a partial thickness groove. Open the anterior chamber with small nick initially and assess before enlarging the incision 360 degree about the intraocular pressure and presence of synechia and all. And one may have to deal with synechia if there are those synechias are present. I have just brought in, very short videos about, how to go about this triple. Here there is a very dense scar, and probably it was nearly impossible to do any of the lamellar procedures for this particular patient. We first mark the cornea with trephine. Here I have taken about 7.5 millimeter trephine. It's better to take at least 7.5 or 8 millimeter, incision. Make a small nick into the incision and make sure that the anterior chamber is well filled with the viscoelastic material, and then start dissecting the cornea. And each time lifting the cornea, make sure that you are not dealing with any synechias, or if you are having synechias there, you have to deal simultaneously with them also. Here, as you can see here, that the corneal scar was, the cornea was pretty badly scarred, and the cataract is also pretty advanced. Sometimes the capsulorhexis could be challenging in such cases when you are dealing with these cases after removing the corneal button, because your chamber is open. If it is a very dense hard cataract, the size of the capsulorhexis should be as good as 5 to 6 millimeter to allow nucleus delivery without complications. Many a times you may not be able to do capsulorhexis, and you may have to do can-opener capsulotomy. If the peripheral cornea permits a capsulorhexis, one can use a cystome and do a rhexis first before removing the actual corneal button. Sometimes one can face small rigid pupil with dense cataract and one can consider doing small multiple sphincterotomies before doing a rhexis or a nucleus delivery to allow nucleus delivery easily and to prevent inadvertent sphincter ruptures during the procedure. Sometimes you can end up into a posterior capsular rupture. The nucleus delivery can be tricky due to pre-existing posterior or anterior synechia. Sometimes there could be auto-expulsion of nucleus or lens capsule complex, and that can mess up your situation. One should have all the options open for such events, and you should have probably a scleral fixation lens ready, or you should have a self-fitted lens ready. Still, or sometimes you may have to do a PK and do a secondary scleral fixation later on. Still, at times, one can end up with troubles and end up with radial tears or a posterior capsular rupture. Selection of an IOL also is a challenge. One can use, especially for open chamber, this kind of cataract surgery, one can use rigid PMMA IOL for better stabilization of the lens, as well as to prevent upthrust of the vitreous during the surgery. The optic size should be preferably larger, maybe about 6 millimeter or so. One may have to keep a standby scleral fixation IOL if it is needed. If synechia release lives behind a large diameter pupil, maybe you could consider doing a pupilloplasty simultaneously. Some people prefer to do a PI simultaneously. It is a surgeon's choice, and surgeon can take a call at the time of surgery what to do for that particular thing. This is a small video showing the cataract removal in an open chamber. You can, here I'm doing a beer can opener capsulotomy. You put small nicks adjacent to each other and make sure that we all are very familiar with this technique. It's important that the pressure should be very stabilized. A very light hydrodissection is done, and you have to here, the nucleus delivery is a little tricky. You have to give gentle pressure step by step to make sure that the nucleus is popped out and gradually rotated with the help of cystitomes, so that you could see that there were, synechias there, and because of that, it was a little tricky. After nucleus delivery, you can remove the cortical. You can do a cortical cleanup with the help of simple cannula. You have to be very, very careful in peeling out the, grabbing it from the pupillary border and peeling out the cortical matter. Sometimes you can grab the end of the capsule and you can end up into troubles. You have to be very gentle in doing this maneuvers. Once the cortical cleanup is done, you can plan putting a rigid PMMA IOL, and again, inserting that lens also is little different than what we do for our cataract surgery, and you have to have a second instrument also sometimes in ready or a spatula ready to make sure that the IOL optic is pressed a little bit, and then dial the rigid lens into the chamber and make sure that the pupil is round so that the haptic is not tucked anywhere in between. And here I'm doing a small PI at the I prefer to do this in this particular case, maybe probably do a PI, and you make sure that the PI is patent. Once that is done, it is always, ideal to punch your cornea beforehand so that in case of any adverse event, you can suture the cornea earlier for these patients. Looking at the type of suturing, preferably interrupted sutures, which should be equidistant, radial to the graft-host junction. Avoid unnecessary intraoperative manipulations once the corneal button is sutured to avoid compromising donor endothelial reserve. And one can try using an intraoperative keratoscope to achieve good astigmatic control, or put in a small air bubble and make sure that while you are suturing, that air bubble remains circular, and that can give you a good guideline regarding your suturing. And at the end conclusion of the surgery, your wound should be watertight. You can walk around the wound with the help of a dry Q-tip or a Merosol sponge, and make sure that your wound is watertight. This is just showing a suturing technique. Sometimes it becomes very difficult if there is a lot of upthrust, then you may have to suture the button early on and then decide to put an IOL. So you suture the button and then again, cut the sutures in the area of the optic size, and then insert the IOL and resuture that area carefully. Fortunately, in this particular case, the pressure was not an issue, and we could do it very well. Make sure that your sutures are radial enough, and you take almost 90% depth on both the sides, the donor as well as the recipient. You all are very familiar with that. And I prefer to take interrupted sutures in all these cases so that it is easier to monitor the astigmatism in the post-operative phase. You can do a selective suture removal in those cases and titrate your astigmatism in the post-operative phase. So once you have put in, sometimes you may have to put 4 or 8 cardinal sutures initially and then insert the lens, or then do a cortical removal if there is a lot of upthrust. But that would also be at the cost of compromising the donor endothelium. Especially in triple procedure, it's important to take care of post-operative inflammation. So you may have to step up your dose of topical steroids in the post-operative phase. Usually the patients are very happy as there is an instant visual rehabilitation if they have a very advanced cataract and a corneal opacity. And one can adjust the sutures to achieve best final corrections later on. I think to summarize again, you have to consider all the factors starting from IOL calculation to planning your surgery, intraoperative problems. You have to keep your option A, B, and C ready if you end up into intraocular certain challenges. And once you are through the procedure, you have to even look at the post-operative rehabilitation for these patients. I think that summarizes my talk. Thank you for your kind attention.
Thank you, Paras. I think you covered almost all the points very well with the video demonstration also. And if there are any questions, I think all questions have been answered in the chat box by the panelists, as well as in the YouTube. I think, Himanshu, you are seeing the YouTube, no questions?
No, I'm not seeing YouTube. I don't think who's on.
Okay, the YouTube questions are posted here.
They are posted in the chat only. So.
Yeah, just a small comment on Paras showed an excellent video. Only thing is that when I'm doing a PK triple, I would almost always use a flaring ring. She did mention it in the choices, but the video didn't show it. So I'm just stressing that I am a great fan of the flaring ring if I'm doing a triple procedure.
Yes, one point I would like to mention is if somebody is not very familiar or in placing the ring, if the ring is not very well placed, sometimes that itself also can cause a lot of pressure changes during the procedure. So one should be very, very well versed. I do use it in pediatric cases and cases wherein I would face a lot of hypotony or those kind of cases. Yes, I do agree to your point, Dr. Muscati.
Dr. Paras, there's one question by Dr. Harishvardhan that in case of scleral fixated IOL in these cases, especially open Skype cases, what are the tips which you can give?
If you have not planned your scleral fixation incisions early on, it is very difficult to manage those cases. And sometimes maybe you could just close your button and in the second stage go ahead and do your scleral fixation IOL. But at times you can put in a small, you can put in your, sutures and maybe 8 cardinal sutures and make the, scleral pockets and go ahead and do a scleral fixation lens. Yes, but it is a very, very sticky situation if you end up into a PCR or, you end up doing a vitrectomy in these cases because of PCR and many other problems.
A 4-flange scleral fixation is relatively simple to perform. Does not require any creation of flap or opening the conjunctiva. You can use a 27 gauge needle and 6-O-Prolene, and in open sky you can very easily bring out, like you can thread the sutures, use cautery, and you can put in a PMMA IOL pretty much easily without having to do a lot of manipulation. So for me, that is my preferred technique. I used to do the Yamane, but in the Yamane, because you have to insert your needle a little tangentially, and in an open sky, sometimes it can be a little difficult. Whereas the 4-flange, the needle goes straight. So I find it's much more easier to perform and less cumbersome. And it can be done very quick. So even if you have an open sky, like your globe is open, you can quickly do that, and it gives a very good stabilization of your IOL.
So I think with this, we will next now come to the next set of speakers, and there are bright young ophthalmologists who are going to be showcasing their videos, 3-minute videos. So first I would request Dr. Rakhi to show her excellent technique of slit beam method of doing cataract surgery or Facoemulsification surgery in a case of combined corneal opacity and cataract. Rakhi?
Thank you, ma'am. Thanks for giving this opportunity. As we all know that, can you pause my video over here? So we all know that cataract surgery is a very challenging task in presence of corneal opacity. So in this video, I'll be describing the technique that really helped me in managing such cases. So The technique involves the use of the slit beam assisted retroillumination instead of using the standard coaxial retroillumination and the endo illuminators. Can you start video, please? So in upper two pictures, you can see that anterior segment visualization is suboptimal, that uses standard coaxial retroillumination, whereas the visualization is quite enhanced in the lower two images where the slit beam assisted retroillumination was used. So in this video, I'm going to demonstrate
Case of 67-year-old man with radiation keratopathy and nuclear cataract who underwent phacoemulsification. Under peribulbar anesthesia, 2.8 mm temporal clear corneal incision was made and the anterior capsule of the lens was stained with trypan blue. However, the visibility of the capsule did not improve enough to perform continuous curvilinear capsular access. So we chose to improve visualization by using slit beam assisted retroillumination. A slit beam of fixed width approximately 2.5 mm was incident on the cornea. Consequently, the resultant reflected light enhanced the fundus red reflex on the opposite side of incident slit beam, thus helping in visualization of anterior capsule. To make CCC temporally under improved red reflex, we placed the slit beam on the nasal cornea and changed vice versa. Hydro procedures and nucleus rotation were performed. Facoemulsification using stop and chop method was performed successfully, and it was followed by cortical irrigation and aspiration using bimanual cannula. Foldable IOL was implanted and the wound hydration was done. This is another case with nuclear sclerosis and posterior subcapsular cataract in right eye with leukomatous central corneal opacity who underwent the similar surgical technique. This is another case of 67-year-old patient with healed fungal keratitis and significant cataract, and here also we adopted the same technique, that is slit beam assisted retroillumination, to get the better visibility of the interior segment.
So with this technique, we nearly performed 20 to 30 cases, and all of them had a good results after the surgery. This technique also has many disadvantages, many limitations, like it is dependent on the red reflex. So we cannot perform this technique, the phacoemulsification with this technique in cases where the cataract is mature, advanced or white, or if the pupil is non-dilated or partly dilated, or in the cases where vitreous hemorrhage is present. So in these cases, we can't get a good glow, and we cannot perform surgery using this technique. Thank you so much.
Thank you, Rakhi. I think it was a very nice set of cases. Dr. Tityal sir, would you like to comment on this?
I think very nicely shown. We know that slit lamp will give you a better retroillumination in these cases. But the problem in such cases would be exactly just underneath the slit. There's no visibility. It's the adjoining area which you see a red glow. But the area which beam is focused, that area is invisible. So that's a challenge for people who are not used to this. Because that's a blind spot for a slit. So that has to be taken into consideration. And otherwise, Rakhi has pointed out all the areas where it cannot be used. In fact, people have used combination of both. You can use a slit as well as a diffuse illumination, which gives accessibility of other areas also. So this is challenging because your view is limited in these cases. Otherwise, it is a good step for, especially for a rhexis. Then subsequently implantation and the polishing is a good area. But during phaco, sometimes you have a blind spot in these cases.
Any other comment? Anybody would like to say anything? We move on to the next case. Next case is by Dr. Shahnawaz, who's working as a consultant at GMC Srinagar. And again, he's going to show a very challenging case. I just wondered how he was able to do phaco in this, and where was the cataract and where was the...
So in regards to all the panelists, thank you KeraKonnect for accepting my video presentation. So I'm presenting a surgical video of a case of Facoemulsification in a corneal opacity. So it's a one-eyed patient with healed keratitis with dense vascularization, a poor candidate for keratoplasty. So we plant a phaco. However, in these cases, one should keep a very low threshold for converting it to ACC or SICS. So patience is the key in these type of cases. And one should always slow down all the steps in these type of cases. Proper staining of the anterior capsule is very important, and rhexis should be of adequate size. Otherwise, it may increase the level of difficulty. Using the rhexis forceps makes the things easier. Here you can see that I was using initially a cystotome, but I changed to forceps because the visibility in the periphery was very poor. The flap in the center was easy to visualize. One should use a soft shell technique because of poor visibility. There is a tendency to do a more anterior phaco. The central part was relatively better, so I'd done a vertical chop here. It is a hard cataract. However, softer cataract may be more difficult to deal in certain cases. All the maneuvers should be done slowly in a very guarded way, as these cases may have accompanied zonal weaknesses and there can be chances of endothelial touch. One should try to make as many pieces of the nucleus as possible. I'm keeping my blunt chopper in front and slightly below the phaco probe, as this may prevent PC accidentally coming in the probe if the AC becomes slightly shallow. Thing has to be done very, very slowly. While injecting the IOL, it is important not to do a wound-assisted delivery and try to put IOL slowly in the back directly. If you are not sure, you can dial with the help of a Sinski. So here the trailing haptic is in the sulcus, so I will just dial it into the back. And you can also check with the help of the Sinski whether it is in the back or in the sulcus. Proper irrigation and aspiration should be done. Because of poor visibility, incomplete removal can cause increased IOP in the post-op period. Wound should be properly secured, and if there is even a slight leak, you should suture in these cases. Lastly, I want to say that I had been extremely lucky to work as a resident in RP Center and work under Dr. Tetial, Dr. Namrata Sharma, Dr. Rajesh, Dr. Tushar, and others. I thank all my teachers for all the teachings and blessings. Thank you.
Thank you, Shahnawaz. Thank you for a very difficult case. There are a couple of questions. One is that in this case, do you think if you would have done a scleral incision, it would have been better, and the corneal edema that occurred at the wound, the corneal wound, would have been less?
There was corneal scarring in the periphery, so it won't matter as such.
But I think there is this thing, Praveen, when do you think you would want to shift to a scleral or a corneal tunnel? How do you decide?
I think that's a chat that's been going on, but I guess if there is pathology in the periphery of the cornea, you certainly would like to use a still tunnel. I think like Nikhil pointed out as well, if there is an ocular surface issue, I think this has been a debate that's gone on for longer than I can remember. If you have somebody with significant amount of dry eye, would you do a corneal incision or would you do a conjunctival peritomy and then a sterile incision? Well, I guess there is no clear answer because there are proponents for both. But I think logically what makes sense is to make a conjunctival peritomy and then a sterile incision, because that seems to leave the ocular surface the least affected after the cataract surgery.
So any other comment or question?
So I also like the scleral incision because sometimes you get stuck and that you may not able to complete the phaco. So in that case, you can easily convert to manually increase the tunnel size without putting the chance of. So in this type of case, I always prefer to do a scleral tunnel. And I make the entry port for phaco only, but if any case, I can easily transfer to manual SICS.
So thank you so much, sir. I think we'll come to the last presentation of the day. That is by Dr. Kavita Rao. It is going to be phaco and Salzmann nodular degeneration. Now, just to extrapolate this further, there are a lot of questions on how do you do in healed PUK cases or patch grafts. So if you do want to see in part 2 of this webinar any specific cases, you can please put in your wishes or whatever you want to see the videos of in the chat box, and then we will get back to the members to see whether people have those cases or not, and put those cases for the next webinar, those topics for the next webinars which you wish to see which are the problems which are unsolved for the next webinar. And of course we will take up, like Dr. Nikhil said, IOL power calculation in these complex situations. So Kavita, can we have your presentation?
Sabina, can you just mute it for just maybe like 2 seconds? Thank you. This is relatively a very simple case. I think Dr. Namrata ma'am, she's already covered phaco in all kinds of corneal opacity. In Salzmann's nodular degeneration, a few practical tips I just wanted to give, that sometimes I feel as a decision making that you may need to do PTK before surgery. I think maybe the panel can address that. Like in this patient, of course, I just went ahead with the phaco surgery. We can start the video. So this is, initial, in this case, as I said, the view is really not that bad. So you use trypan blue for, I've already finished the rexes. As you can see, most of the degeneration is, you can see a little bit of degeneration in the center. After using trypan blue and soft shell technique then for phaco, when I'm trying to make a groove, I think I'm not really getting a very good crack, and I'm not able to see the posterior plate. I think the Raki showed a very good video where you can probably use a slit, but I'm not sure in this case how much it would have helped. As you can see, it's a relatively dense cataract. I've got a crack, and then I'm trying to do most of the phaco. I'm actually doing it a little bit closer to the endothelium than I would do normally. While operating, I felt the view was not really good. It wasn't really not getting too much of a retro. Only once you start eating the cataract pieces, I can see that you can see some of the red glow is in the eye. Here I've the piece has come very close to the endothelium. So after I tackle that piece last after inserting more visco in the eye. The other tip is, after, we can fast forward this a bit. This is what I was saying. After putting visco, I've tackled that piece. The other tip which I wanted to give was that maybe in such cases, it may be better to use the IA tip for doing the epinucleus removal. Though if for expert phaco surgeons, they can very well do it with the phaco tip. But I feel like, at least in my hands, when the view is compromised, even though this step can take longer, and, sometimes, because if the epinucleus is thick, the plate is thick, you may take a little bit longer, but I feel if the view is compromised, this can be a good tip. And at the end of epinucleus removal, of course, putting the IOL in the bag and closing the plate. So now I think with the red glow, we can see some that the view has kind of improved, and the IOL is placed in the bag, and that's the end of surgery. You can stop the video, Shabina. We could take any questions.
So I have a comment here. Hello.
Yes, yes, sir.
The nodule is elevated, what I could understand. So in this type of cases, it is better to treat the SND, I mean Salzmann nodular degeneration first, because the biometry error is huge in this type of cases. You get a lot of toric. Even I have several cases where the biometry calculation is ±4 difference. And your visibility, of course, will enhance. So you remove the nodule and you do a diamond bar polishing and wait for 6 weeks, and you have a better biometry reading and, of course, a better surgery. So this is a huge nodule in the center, almost paracentral region.
No, I definitely agree with you, sir. Your point is very valid. I think this patient was not willing for the corneal surgery, but yes, and your point is very valid, sir. So, do you think just removal with the burr is recommended, or in what cases do we decide to do PTK?
The PTK is not initially, you do PTK is a costly and institute affair. If you, in your normal setup, you just use 2 forceps, fine forceps, and you just peel it off. It nicely peeled off, and there is a suborbitous scarring, and then you polish with a diamond bar and put a bandage contact lens for 4 to 6 weeks and recalculate the biometry and do the surgery after minimum after 6 weeks.
Kavita, PTK may not help here because the elevated nodule would not allow the PTK to be done properly. As such, you have to do deepitalization for that, and that itself would take care of the nodule. So,
what I meant is after we remove the epithelium, then on table, then should we shoot for the
after doing a keratectomy, I mean after removing it with the help of the forceps or whatever, then you can do about 15 microns of PTK to smoothen the whole thing. Dr. Tityal sir, would you like to say something? I think that is how we've been managing, cases of PTK.
Yeah, that's correct. What Dr. Samar was saying is a good point. First, we have to regularize the corneal surface, then do surgery for these patients. But sometimes these cases can have scars also. And we have done cases with superficial lamellar keratoplasty or a SALK type of procedure, which take care of a surface irregularity as well as the little scar which they may have. But I can understand some cases they do have a very significant cataract, what Kavita was talking about. In such cases, the central area is okay. You have a regular keratometry central area. I might go with the phaco or a cataract surgery first in such cases where one-eyed patient, the patient doesn't want to wait for a regularization of surface. But normally these patients are, they do have a bilateral problem. They also have ocular surface disease. So everything has to be taken into consideration. The PTK or the corneal surface procedures can sometimes deteriorate the ocular surface also. So we have to judge in both ways. This particular case, maybe I would have gone with the cataract surgery if the corneal parameters were quite okay. But other way around also, what Samar was saying is also correct.
Does anyone on the panel have ever had to do a penetrating graft for a patient with Salzmann? Because in this patient, her other eye actually was very dense, the Salzmann. And as I said, she was not very keen for a cornea procedure. She was not from Mumbai.
I think you would always get away with the anterior lamellar procedure. Maybe you have to go a little deeper, but if the scar is deeper, but I think you would always see that the underlying, endothelium would be clear.
I think Namrata has published the largest number of one series of cases where we had done an automated lamellar keratoplasty for these patients with nodular keratopathy. And these patients do very well. And I think we are the first people to publish the comparative results of automated dissection versus the manual dissection. And we found that cases of the automated dissection, because both your graft and the host surface is very smooth. So you have a lesser interface problem in these cases, because interface does become a problem in a manual dissection in anterior lamellar keratoplasty cases. So I can understand if you have an automated system nowadays, if we have to do less than around 250 micron or less, we don't require suture also, because we fashion the post cut as well as the graft cut in such a manner it very naturally coapts the peripheral area. And we keep bandage contact lens for 6 to 8 weeks for these patients with the fibrin glue attachment on the table, and they do very well.
Okay, I think with this we come to the conclusion of this webinar. We had planned it like this, and I think we thought we would have the course sort of a thing first, and then we could have people presenting their just cases and just videos for the next time. So it will be just a problem-based webinar for the next time. Dr. Nikhil, would you want to? Nikhil?
Yeah.
Would you want to say about it?
Yeah, no, so the next, I mean, I just thought that we need to acknowledge the sponsor, if you can do that, and of course,
Yeah.
the next one.
So, okay, people want to go for dinner. So we would like to thank Lupin for supporting this webinar and supporting our future webinars also from Cornea Society of India. On behalf of all the members of Cornea Society of India, we would like to thank them. And please do submit for the next webinar, which is going to be on 25th July at 6 p.m. So we are going to discuss the IOL powers calculation in the presence of corneal haze. How do you calculate the IOL power, and also just cases and just videos. So each case or video would be around 4 minutes, and when you give in your submissions, we will select based on that. So thank you everybody for watching it. Thank you, and thank you Hallmark for Hallmark Events for organizing this at the back end.